we've made it from the SA node to the atria. Now we're going to the AV junction. And to understand what's happening here, let's take a look at the AV node itself. AV node is actually a pretty interesting part of the heart that can have several different characteristics. Like standing here. But it can have several different characteristics on the strip itself. And actually, the site of origination within the AV node itself can actually affect the way that the P wave looks, and it also can affect the way that the QRS looks. And so we'll just take a quick look at that. That's in chapter 21 in the book. But if you notice with your AV node, so we know the location of the AV node. It's going to be just inferior to the atria, but there's a transitional area in between the atria and the AV node. Now, it mentions in your book that there can be 1 or 2 tracks that supply the electrical conduction to the AV node, but what we do know is that in the healthy heart, in the normal heart, that we've got almost like that wall doesn't allow for conduction to go through except through the AV node to keep from aberrant pathways or non-normal pathways to occur to get to the ventricle, so you don't have early depolarization and things like that. So all of this is designed here so that that conduction can have the momentary physiologic block. Remember that? We have that momentary block right there so that we can allow for what? Ventricular filling via the atrial kick, right? So we have to allow for the atrial kick to occur so that we can get ventricular filling so that we can get a good stretch, right? So you've got within the AV node itself, you've got the transitional cell zone, which is going to be right at the floor of the atria into the AV node, okay? So it's not like you just have one structure. It's not like you just have atria. Well, if you think internodal pathways through the atria, then suddenly AV node, then suddenly bundle of His. You've got transitional cells, all right? And so the histology, and when we say histology, we mean the cellular makeup is a little different with each one of these, and it's all anatomically that way so that it can perform its specific job. Now again, you got to think about the way that the heart is designed is to design for the SA node to fire and all of these different tracks here to just accept that action potential as it goes through the heart, right? But we also know that properties of cells say that you've got automaticity and irritability, which are the two main reasons why ectopic foci occur, is the irritability than the automaticity. And so any of the cells within these zones here can actually cause sites of ectopy, okay? So in with the anatomy here, your book for right now only shows a picture of just one tract, just for simplicity. But you've got the approach here, which is the tract of the conduction, then you've got the transitional cell zone. And the transitional cell zone, autonomic, full of autonomic fibers, and it is very arrhythmogenic. What is arrhythmogenic?
Produces rhythms.
Yep. So that's what I thought it meant too, and that is correct, but that's not a term we use very often in here, but arrhythmogenic. So it means that it's got, I don't want to say unstable cells, but it's got cells that will respond to the autonomic nervous system very easily and will actually be sites of irritability as well. So it's a small area of tissue that surrounds the tip of the AV node. So again, that's going to be right there at the atria. Then you got the compact zone. So the compact zone, this is kind of, when we think of the AV node, this is kind of the cells that we think of as the AV node. And as a matter of fact, when we talk about AV paced rhythms today, that's the site that those are going to originate from. All right? So it's composed of cells that are similar to those found in the SA node. So what are the cells in the SA node supposed to do? Pace, right? They're supposed to pace. Y'all act like I give y'all trick questions all the time. You're like, I think you need space. Maybe I just don't answer questions or ask questions well, but so it has pacemaker cells, right? From the very first day, simply it's pacemaker cells. So this is going to be where your primary function would be if the AV node had to take over. Now, think about this. We said that the SA node, the intrinsic firing rate of the SA node is what? 60 to 100. All right? So if AV node had to take over pacing, what would the intrinsic firing rate be?
40 to 60.
40 to 60, with some exceptions when we talk about some tachyarrhythmias, but with our junctional rhythms, that's going to be what we consider the normal rate. Even though it's not normal, because there's nothing normal about the AV node having to take over pacing, that's rates that we're going to be looking at, okay? So, about 90% of people's normal anatomy, so about 90% of the population, the RCA, the right coronary artery, is what supplies the AV node, okay? The other 10% is going to be like the circumflex artery that comes off the left. But I tell you that right now because when we get into 12 lead, one of the things that we're going to see is inferior MI. So y'all saw inferior MI in lab the other day, right? He showed you where it was 2, 3 AVF and all that. Inferior MI is often associated with AV blocks or bradycardia rhythms, and it's because a large portion of the inferior part of the heart is supplied usually by the RCA or the circumflex. And so this essentially the same arteries that would supply here would supply the lower portion of the heart as well. All right? So when the AV node fires, so if you've read in your book, one of the chapters that the interpreting rhythms chapter in your book, I didn't use. It's a little chilly in here. I didn't use because it gave examples of every single rhythm, and I didn't want to get the cart too far ahead of the horse, if that makes sense. But what it did do was give some graphics in there that kind of helps us make heads or tails of what's happening with electrical conduction, right? So we kind of talked about retrograde conduction before, and retrograde conduction that happens below the atria is going to cause the P wave to look like what?
Down. Inverted.
It's going to be inverted, right? So the image that he uses here is that if you can imagine that you got the atria and you got the ventricles, and initially these doors are closed, right? But this is full of water, right? What happens when both of these doors open at the same time? The water's going to go both ways, right? But they're going to occur at the exact same time, right? Does that make sense? The atria is going to fill up and the ventricles are going to fill up. So think about that with electricity. When it fires, they're both going to occur at the same time, all right? Which one requires more electricity to contract? The ventricles. So what's going to show up on your monitor? The ventricles. So when we talk about like some SVTs or even junctional rhythms that are pacing and all, and we talk about there's not a P wave there, it's not necessarily that the atria is not being contracted. It's just being contracted at the same time or sometimes even a little more delayed than the ventricles are, all right? Now, think about this though. If this is the AV node and this opens up, normal conduction would say that conduction would go through the AV node to the ventricles this way, right? Or in this case, from a superior to inferior, right? So from the AV node down, there's typically not going to be any change in the ventricle. Unless it is a fast rate, which is causing the ventricles just to contract really quickly. So you should have a real tight QRS. Sometimes in your tachyarrhythmias, your QRS is going to be, 0.08, 0.06. It's going to be a lot tighter, right? But with your AV node, with your AV nodal conduction, typically, now there are some exceptions, but typically your conduction is going into your ventricles like it normally should. So again, just like with the atrial arrhythmias last week, we haven't made it to where the issues are occurring in the ventricles. So everything that shows up as far as ventricular conduction should look relatively normal. Does that make sense? Yes? All right. Now, as far as what your P waves are going to look like, and this is going to, I'm going to try to make a little bit of heads or tails of this. Let's say, all right, so we know that this is the compact zone. This was called the transitional area, right? So let's say that your ectopic foci, and your ectopic foci is what? What is the ectopic foci? Right, so it's the site of origination somewhere other than the normal conduction pathway, right? Now, let's say that it's very low in the atria, right? But it hasn't, it's low in the atria, but it's still just above the physiologic block in the AV node. All right, so we're talking about that microseconds that it blocks, right? So it's right there on the line, but it's still going to block the conduction through the AV node briefly, right? Because remember, the compact zone is really what we're talking about as far as like AV nodal tissue, right? They're all part of the same general area, so you can almost, I guess you would really say like the transition zone would be what we would consider the AV junction, right? So let's say that happens. Well, we know that if it occurs low in the atria, the conduction's still going to go retrograde, right? But that pause is still right there. The same pause that the SA node would have if it fired down, that pause is still there, okay? So what that does is that allows for us to see the retrograde conduction here, okay? So what that does is that causes the atria to conduct retrograde really quickly, but then it allows that conduction to go on through, okay? So that's why you might see an inverted P wave, because it is lower in the conduction, okay? Now, what about a retrograde? Well, let me back up. So what you would see with this is you would see a very short PRI, right? It makes sense because it's not necessarily traveling through the atria to get to that block. So you're going to see a shortened PRI, but with this, what about a post-QRS P wave? A post-QRS P wave. Well, think about what's happening here. We're still in this area, and it's right at that transitional period between the compact zone of the AV node and right at the bundle of pits, right? So what's going to happen if this conduction, so we're talking about it's already starting to enter into the QRS, okay? It's not at that, this would be that site, this would be the site of the physiologic block. Are y'all following me here? Does it make sense? So we're not going to have any period of time that it's held up, okay? So what's going to happen when this thing fires? It's going to go up and down, right? But what's going to happen in this case is that the ventricle's actually going to fire quicker than the retrograde atrial conduction is going to fire, but we're still going to pick it up on the monitor because it is going to occur. All right? So it's almost timed perfectly. It's not very often that you would see this, okay? But it can happen. A post-QRS P wave can occur, all right? And so this is just kind of an introduction. We'll see some of this in some of these arrhythmias that are coming up, but I want y'all to kind of understand what's happening at the AV node in order for these to occur. All right? All right. 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 So, if you associate this slider right here with the AV node, and the colors are the AV node, so the green would be, what was this area called? The transitional, then that's the compact, and then we're getting on into the bundle of His area here, okay? So if it occurs high in this area where we're at atrial tissue that's transitioning into AV nodal tissue, you're going to, and it's still above the physiologic block, then you're going to see an inverted P wave right there, okay? If it's more in this compact zone right here, notice where your P wave's at. It's right here. Now, the only thing that it may do is you may see a little bit of like a little bleb or something here, but it's not going to be enough for us to really identify, okay? Does that make sense? So what's happening is that P wave, the site of impact is occurring right here, and it's going up, and it is retrograde conduction, but at the same time, that's what I was talking about with the water, right? Okay? And then if it's lower in the bundle of His, all right, or if it's lower in this area here, but we haven't got to ventricular tissue yet, then you may see a retrograde. You will see a retrograde and a post-QRS P wave. All right? So remember, I was talking about our rates here, okay? So what we're going to see when we get into, the first thing we're going to see is a PJC. Second thing we're going to see is a junctional rhythm, then an accelerated junctional, then a junctional tachycardia, okay? With your junctional rhythm, less than 60, what's my intrinsic rate of my AV node or the compact zone of my AV node? 40 to 60, okay? My accelerated junctional, that's going to be 60 to 100. Then my junctional tachycardia is going to be greater than 100. And one thing that when we get to junctional tachycardia, you're going to see is that it's really hard to differentiate it and an SVT. Okay? All right. Premature junctional complex. When do you think this contraction is going to occur?
Earlier than it's supposed to.
Premature, right? Earlier than your next expected beat. So as far as the rules for a premature complex, it's going to follow the rules of just like a PAC, right? It's going to occur before our next expected beat, and the concepts of bigeminy, trigeminy could occur with this, all right? And then also the idea of compensatory and non-compensatory could occur with this as well, okay? But just taking a stab in the dark here from what we just talked about, what do you think we're going to see that's going to identify this as a PJC? No P wave, inverted P wave, or post-QRS P wave, but it looks different than your underlying rhythm, all right? These are usually easier to see, easier to identify than a PAC is. Okay? So we're trucking along, then suddenly we've got this complex. Now notice, what does a QRS look like?
Same.
It's the same, right? Because there's no issue with the ventricle right now. But what do we not have? P wave. All right. Now, a couple of ways that we could tell, because remember with our PACs, we did see at times some inverted P waves, and there's a couple things that you can do to identify that when you get a 12 lead. I'm not going to worry about a 12 lead right now, but you would look at 2, 3, and AVF. And then we'd also look at the preceding T wave as well. Okay? Now, one thing that I can do here is remember when you have that convergence of a P wave and a T wave, and you get that little bit bigger, what little bit bigger T wave right here. So that's one idea there, because remember, when we look at PJCs, all the T waves look the same, right? Also, look at your QRS as well. Okay? All right, so what are my rules here? The rate of the underlying rhythm plus your PJC, because it is creating a QRS, okay? So that's going to be your rate. The rhythm, it's usually regular except for your premature beat, but we're going to have a disruption in our overall R to R, so we're going to identify that as irregular, okay? The P waves, so look at your underlying rhythm. They should typically be sinus, okay? Sometimes, well, let's just leave it at that. For the PJC itself, though, it's either going to be inverted or absent, and sometimes it may be inverted in post-QRS. The PR intervals, so the PR intervals should be within normal limits for your underlying rhythm. If you have a retrograde P wave pre-QRS, you would just measure PRI the same way, okay? And then your QRS complexes should all look alike across the board, all right? So where's your PJC in this?
Third one.
Your third one. So what's your underlying rhythm?
Sinus.
It's a sinus rhythm with PJCs. Now, if we had a little bit more, we might actually identify it as a sinus rhythm with quadgemini PJCs, but I don't have enough here. I gotta determine a pattern first, right? Because you got a PJC right there and you got a PJC right there. But now look at my T waves. They all look the same across the board. Look at my QRSs. They all look the same across the board. There's no convergence or merging of a P and a T. So this is going to be a definite PJC. All right? A lot of the same things that can cause irritability within the heart, anxiety, fatigue, stimulants, heart disease, electrolyte disorders. All right? So let's take a look at a couple of them. All right? So figure 22, example 1. All right, so my underlying rhythm, well, let's just go in the steps. All right, so I got 1, 2, 3, 4, 5. Am I counting this? Yes. 6, 7, 8. All right, so the rate's 80. All right. It is irregular because I got a disruption in my R to R right here. Okay. All right, so my P wave for my underlying looks good, doesn't it? The QRS doesn't look beautiful, but the QRS is uniform, so we're okay with it. But my P wave looks good. My PRI for my underlying would be about 1, 0, 1, 2, 3, 4, about 0, 1, 6 or so. All right. Then my QRS, my measurement for my QRS is about 0, 1, 0 or so. Well, yeah. 0, 1, 0. All right. Now, one of the things that if you're looking at this, don't get confused, because look, your P waves, they all look similar, but then look at this right here. It's very similar in the morphology of the T wave, right? So that's actually the T wave that's coming off of here, all right? our next expected beat should have occurred somewhere around in there, right? But this guy shows up. Hey guys, what's up? Just PJC here. Right? Now, if I just see this, the patient is perfusing fine and all that, I've got a rate of 80, there's really, there's no treatment that we're really concerned of here, all right? Paramedic student for a PJC is to identify it on your quiz, identify it in your test, and then identify it if you see it in clinicals, and, you know, kind of watch to see if there's any changes, okay? This one's a little bit tougher. Why are y'all so quiet today? You're acting like a hurricane stuff. This one's a little bit tougher just because of some of the morphology here.
So is that the two-way bar that next to it?
Well, and that's what I was going to say. If you notice, yeah, so that is. Now, I would say that one is kind of hard, but the way that I do know this is a premature beat is because it's occurring prematurely, right? But if I look at my QT interval there, and I know that we haven't talked a lot about that, but my QT interval there is going to be the same as that one. All right, so that tells me that is. Now, again, the reason why I say that's really kind of confusing here is because if you were just at first glance, you're like, hey, that does look like a P wave. But look at the underlying P waves. It has this noticeable notch right there. So it does look different than that, okay?
Is that the third pitch scoop?
It's not, I think this is more of like a little bit of ST depression, and it may not even necessarily be from SMI or anything like that, but it's not as dramatic as a scoop would be. All right? What's happening here? This one's really kind of weird. It says right here, the cadence of the ventricular complexes is broken up by a premature complex that is narrow and similar in morphology to the rest of the complexes. This is obviously a PJC because if I were taking my calipers and trying to see if it's regular, this does occur prematurely. The cadence of atrial complexes, however, is not broken and persists through the PJC. So what are you seeing right here? Yeah, so you're actually seeing this kind of merged into that. So you got a whole bunch of stuff that's kind of happening right now, right? But what's happened here is that PJCs actually cause ventricular conduction. So this P wave right here is not causing it because P wave would be hitting the ventricles during the refractory period. Does that make sense? So whatever caused this in the the AV node has already caused the ventricles to contract, right? The SA node fired, and if that wasn't there, then that complex would look like that. But the SA node fired, this conduction made it through and got to the ventricle, and it's like, oh, you started without me. Cool. And so then the SA node had to start firing again. All right? Now, does it make sense? The author of this textbook went out and found some of the hardest strips for entry level for learning this and was like, hey, let's just throw them for a loop early on. But that's one of the things about heart rhythms that y'all have already probably seen working. There's no two sinus rhythms that look perfect, right? But I do like some of the other textbooks examples at times when they're a little bit easier to identify. All right, what about this guy right here? I don't like this one too much. But if, when we get to ventricular conduction, when we get to ventricular rhythms, even the book right here says that it is difficult to determine whether this is a PJC or a PVC. All right. If you were to put PVC on there, I would not count that wrong because it is an aberrantly conducted PJC, meaning that it is occurring outside of the normal complex or the normal conduction. But one of the rules that we said about the PJC is that typically the QRS looks the same and this one doesn't. So I would not hold you to that to where it's like, oh, I mean, because honestly, if we saw this occur more frequently, then it would probably be more important. Like if we had this patient and we started seeing these occur more frequently, it probably would be more important for us to determine is it a PVC or a PJC. But for this, I'm not worried about it. Right? So on this one, once again, we're faced with a diagnostic challenge. Are the wide premature complexes on this junctional or ventricular origin? How do both aberrant beats start? They start with positive waves that are identical to the start of the sinus QRS complexes. All right? Even though it's tiny, that is still a positive R wave. Then an aberrancy begins to develop along a slightly different location for each one, accounting for the slight differences in morphology between the two. Look, there and there. If you were to follow the rules of a PVC, that's probably going to, because that's greater than 0, 1, 2. All right. Let's just move on. Finally, one that we can all see. Where is it?
The third one.
The third one. We're looking at the preceding T wave. It looks like the others. The underlying rhythm looks normal. We got a QRS that matches up with everything else. PJC all day long. Same thing here. That's funky. Funky, 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 funky. Almost looks like a set of lips, don't it? And we'll see when we get into atrial abnormalities with 12 lead, we'll see what causes that. But right now, what we're just looking at is, are the P waves, they look the same. And they do. But where's your P wave here? You ain't got no P wave. All right? Any questions? Clear as mud? Clear as mud that's going to be created by a hurricane here in a little while? Awesome. All right, now we're going to get into junctional rhythms, all right? So we were talking about junctional complexes, premature junctional complexes. Now we're getting more into pacing from the junction, or the AV. So this is where the AV node is going to pick up as primary pacemaker. All right. If you were to measure, all right, is this on your paper there? Take your calipers and measure the regularity there And then find out where the next QRS is supposed to land after this one where we have this complex. Is it before or after this complex? This one right here. So if I were to take that, where would my next one fall? Yes, so it would fall before, right? What's my rule for a PJC, a premature junctional complex or contraction?
It's premature.
It occurs before my next expected beat. Well, when does this occur? After my next expected beat. So what this is a junctional escape beat. All right, so what basically is happening here is that the junction is kind of gearing up ready. The AV node's gearing up ready, and it's like, should I pay, should I not? Something's going on here, right? So the rules for a junctional escape complex are the same as PJC, except for instead of occurring before your next expected beat, it occurs after your next expected beat. Okay? That's really all we're going to see with the junctional escape beat right now. All right? Your junctional escape rhythm. All right, so your junctional escape rhythm. The rules here. Number one, it's on arrhythmia. So if you identify it, you would identify it as a junctional rhythm or junctional escape. The rate should be 40 to 60, okay? If you see this rhythm, but the rate is less than 40, just call it a junctional bradycardia. Or a junctional escape bradycardia, okay? But what you see is at least 3 complexes are junctional escape complexes, so what we saw just a minute ago. But with what I'm going to give you, the whole rhythm is going to be that way. Your P waves are either going to be absent, inverted, or post-QRS. All right? A junctional escape rhythm arises from a single site in the AV junction or in the AV node in the compact zone. This is the site of junctional pacing, okay? That's why it's a junctional, it's at the AV junction, okay? If present, the PR will be shorter than normal. Okay? So my rules. Rate's usually 40 to 60. What's the rhythm? It's usually regular. Irregular if isolated junctional escape beat is present. That's usually not going to occur. The P wave before each QRS either is going to be absent or inverted. So if we see a P wave that's inverted, you would identify that P wave as inverted. If you see a P wave after the QRS that's inverted, it would be identified as inverted post-QRS. All right? Now, you can get a PRI if it's a pre-inverted P wave. Okay? You cannot get a PRI if it is a post-inverted P wave. If there is no P wave, and very rare are you going to see one that's post. I think I've got one maybe on a quiz, so be looking for that. But very rare are you going to see a post QRS P wave. But if it is absent, just put absent and you can't get a PRI. Okay? Now again, what about my QRSs? Well, again, it's the same concept that we've been talking about this whole time. Your QRSs are going to look very simple. All right. So, my heart rate. 1, 2, 3, 4, 50. Is it regular? It is regular. What about my P wave?
Inverted.
Inverted. So, my PRI. Let's say is. It's around 0.10012. What's my normal PRI?
.12.2.
Yes, 0.12 to 0.2, but it makes sense why that would be shorter, right? Because the conduction's occurring lower, okay? But now my QRS, it's fine, it's about 0.08 or so. And all my QRSs look the same. So this would be a junctional escape rhythm, all right? Some drugs that can cause this: digoxin, beta blockers, calcium channel blockers. If you start having SA node dysfunction, so this is one of the physiological reasons is going to be sick sinus syndrome or SA node dysfunction. The SA node, for whatever reason, is not able to take over pacing. Atrial ectopic foci don't pick up anything. AV node will pick up, and now we'll start having our junctional escape rhythms. Okay. All right, so this is, the whole rhythm itself is not a junctional escape rhythm. What is this? What?
I said it's just work.
All right, so it did go inverted, but it does occur after our next expected beat. So this would actually just be a junctional escape complex. All right, same rules as a PJC, except a PJC would occur here. This occurs here. Make sense?
So if you get a pattern, it's really just one or two that's complex.
Yes, and it just all depends on where it falls. All right, so this one, the same thing. Now this one is a little bit wonky because actually you've got a underlying ectopic atrial rhythm. All right, the reason that is showing like that is because the area of ectopy is very low in the atria, okay? But the only way that I'm going to really realize that versus is it a junctional escape is one reason and one reason only. And what is it? And y'all can see it. It's the second to the end complex. A junctional escape complex is thrown in there. I'm not going to give you anything that complex, like where I would count it wrong if you didn't. All right. Same thing here. They're just throwing us a whole bunch of junctional escape complexes. Those are pretty easy to see. This one actually would be a sinus. This is actually paroxysmal. If I were to see more of this, I would actually probably see that now I'm going into a junctional escape rhythm. All right, so what happened here? Well, somebody explain to me, what do you think happened here?
I think the SA node was over pacemaking at the start, and then it switched over to the AV node.
Yes, that's 100%. Something happened with the SA node. The SA node was firing along, and then it croaked. It said, Lord, I'm coming home, I'm dead. And it croaked, and it went into a sinus arrest. Y'all seen this before, haven't you? And then you got one little failed attempt there, and then suddenly the AV node's like, well, we're going to die if he gave up just like that, so we're going to take over. And now the AV node, I mean, it occurs like that, right? I mean, at some point, that rhythm's going to transition to the AV escape, the junctional escape, right? You just happen to catch it on the monitor when it happened this time. All right? So using what you've already learned, that's how stuff builds on here. Using what you've already learned, you're able to figure out what's happening here. Now, we don't know the patient's history. We don't know exactly what's happening, but just off of this visual graphic here, they were in a sinus rhythm. They went into sinus arrest. The AV node said, okay, here we go, Leroy Jenkins. Let's do this, boys. Does anybody know what Leroy Jenkins is? I have to do this every single The older I get, like, before TikTok, before all of this, well, used to there was none of it, but then when YouTube came out, we started having break.com and different websites where you have viral videos. Okay, moving forward. I'm gonna have to erase that. All right. Simply, what do you got right here?
Junctional escape rhythm.
Where's your P wave? Look at it on your paper if you don't see it here. This is probably one of the clearest ones that you'll ever see. So there is a post QRS P wave. Now what's so hard about this is that you've got a bunch of other stuff occurring at the same time, and so this S wave is kind of merging in with that. Now, what do we know about an S wave? An S wave is supposed to come down and be sharp, right? It's not really supposed to do like that. If an S wave does like that below the baseline, a lot of times it's going to be like some ST depression or something like that, or it may be some other issue, digoxin, which is going to be very dramatic or whatever. But it doesn't really do that, right? It's not sharp. So the atria is getting retrograde conduction there, right? So what are we going to call this?
Junctional escape.
Oh, y'all are so good. Another one. Now this one is not as dramatic, but you can still see it. Be confident in these, okay? Like if you see that, if this was the first time you ever saw this and we hadn't talked about post-QRS P waves and all that, I could very easily see how you would be like, I think that's just part of it. But there's a couple of things that are going on here. You've got QRSs that are the same. You have no preceding P wave, inverted, positive, whatever. There's nothing there, right? You got T waves that are well defined, that look good, right? Then you got this little right there that shouldn't be there. So that is your inverted P wave. Okay? You good? Don't get confused now. What does this kind of look like?
AFib.
Not VFib, AFib or fibrillating baseline. But what is the first thing that you see on here that makes this not AFib? They're regular. It's regular. What is the first rule of AFib?
Irregular.
Is irregularly irregular. All right. So I've always kind of gotten a little confused in textbooks when they say something can very easily be confused with AFib, because you're not. If you confuse this with atrial fibrillation, you're not following your system. You're not following your rules correctly, right? Because your rules, your rate, your rhythm, right? Your P wave. This may be something, but I'm not going to. I'm not going to step out on a limb and say, hey, that's an inverted P wave. All right, that probably is something there. I'm not. I'm just going to say it's absent. All right. But my QRSs are fine. I do have a little swoop right there. Let's see what the book says about it. Yeah, they're saying there's no discernible P waves either. All right? Makes sense? All right. What is this one pointing at? Okay, so this is pointing to a obvious upward deflected wave, because this is not a P wave. This is a U wave. This is one of those rare occurrences where you see a U wave. All right, it's not really there, a little bit there. All right. The U wave doesn't have any bearing with us. If you see this, you're going to say, hey, there is no P wave. The QRSs are all similar, the T-waves are all similar, this is a junctional rhythm. All right, and so what rate does this have to be in order for us to call it a junctional escape rhythm only? 40 to 60, all right? Remember that, because when we come back from break, now we're going to look at a lot of the same rules, but the rate's going to be different.